Absolutely. Are we using the microphone? I don't think I need it. I can talk pretty loud.
We might need it.
Are you guys trying to get started?
No, not yet.
We're just getting ready to get started.
So let me know when you're ready. Are you going to use the mic or
Yeah.
when you're using it?
Yeah, I guess we'll use the mic.
So you better, it's live, I think. No?
Testing.
No,
click on?
I think you use this one. And then, that one's only for extra speakers, and then you have to stand over there. So it's this one, and then he's like, those poses are kind of like your lapel. Right, that's the one.
Testing.
Yeah, that was perfect. So when you guys are ready,
Just speak into that.
Okay, ready? Good morning, everyone. So welcome and thank you all for attending our third annual Georgian Bay Healthcare Wellness Research and Innovation Day. We're a group of post-secondary students who are working on Research Day as we are all aspiring to be the next generation of healthcare professionals in Ontario. We want to thank you for the opportunity to learn and train in this community.
So, it is our privilege to introduce Dr. Michael Lisi, Chief of Staff and Surgeon at Collingwood General and Marine Hospital, who has been recognized by Health Quality Ontario for his leadership with today's event. Please welcome our leader, the Chair of Georgian Bay Research Day 2018, Dr. Michael Lisi.
Collaboration between the Collingwood General Marine Hospital, the Rural Ontario Medical Program, the Town of Collingwood, and Georgian College. And some of our goals here today are to give you an opportunity to network, learn, and explore some of the great research and quality initiatives taking place in southern Georgian Bay. As you will see outside this room, our community has come together to contribute over 40 posters outlining the great work that people are doing in southern Georgian Bay. If you take a look around at your fellow attendees, you will see representatives from a wide range of organizations as well as community members. In your handout, you have been given an evaluation form and draw tickets, and we kindly ask that you fill these out at the end of all your presentations today to let us know how the day went and the chance to win a prize. We are very excited that you're all able to join us, and I want to thank those that are able to make it in person today, in addition to those that are live streaming right now. For those that are going to be posting to Twitter, Instagram, Facebook, please use the hashtag capital G Bay Research Day, all one word, G Bay Research Day. There's opportunities to review posters at 10 a.m. as well as at 12:25 or 12:30ish. And there are some refreshments available in the cafeteria, so please help yourselves. And there'll be opportunities to ask questions after each speaker. But you can see that the itinerary reflects my ADH personality. It's short and snappy. So we're going to try to keep moving along here and try to stick to our schedule. Our focus for Research Day this year is geriatrics. And according to StatsCan, the South Georgian Bay area is one of Ontario's fastest growing region, with an abundance of retirees moving to the area. At present, our growth rate for 65 plus is trending at over 35% over the provincial average by 2022. In 2015, the average cost to our healthcare system of someone aged 65 to 69 was $6,568. For those between 80 and 84, the average cost rose to $15,071. And while just 16.7% of Ontarians are now over 65, that number is set to rise to 25% by 2040. Just something to think about as we begin our day. And in that fashion, I'd like to introduce Dr. Peter Wells, the Executive Director of the Rural Ontario Medical Program, to say a few words.
Thank you to all of you. It's great to see such a fantastic turnout today. I want to welcome you to our research day. I'm not going to try and say that mouthful. Mike Lisi's done it once, and so that's good. We'll just leave it at that. The Rural Ontario Medical Program provides training opportunities for medical students and residents in 60 communities across the province. So it's fairly widespread, but multiple of our communities are in the South Georgian Bay area. So we're well ensconced in your communities. ROMP is an enthusiastic partner. In the research day, it's an excellent opportunity to highlight the fact that important health research does occur in rural areas, not just in the urban and academic settings. So we have a fantastic lineup of speakers presenting today and great opportunities to network with them and with partners from a variety of professional backgrounds. So I'd encourage you to do that. It is an interprofessional day, so I'd encourage you to connect with people from outside your profession and ask them about their work. And we can all learn from each other. So once again, welcome. I hope it's a fantastic day. And as Dr. Lisi said, we want to keep it short and snappy, so I'm going to sign off. And have a great day, and I'm happy to mingle with you afterwards and answer any questions.
Thank you, Peter. So I'd like to introduce Dr. Ann Josephus. She's a psychiatrist at our Community Mental Health to say some opening remarks.
Thank you, Michael, and I'm not short and snappy. And I really don't know why I've been asked to be part of this illustrious panel, except that I might be a living specimen of the new geriatric person. So geriatrics, and those of us who like to do geriatrics know that it's a lot about history and about storytelling. And I'm going to tell you a little story and hopefully set the tone for today's meeting. 30 years ago, almost to the day, in 1988, I was recruited and started practicing psychiatry here at the Community Mental Health Service at the Collingwood General and Marine Hospital. And so I have learned a lot of things over 30 years. And Michelle asked me to condense all of those things into 3 minutes. So I'm going to talk for 3 minutes about the 3 truths that I have learned as a practicing psychiatrist in a rural setting. Truth number 1, it takes courage to live. And the longer we live, the more courage is demanded of us. Not the stupid, crazy, love kind of courage that drew me to Collingwood. That is not courage. That was a lot of things, but not courage. It also is not the type of courage that allowed me to stay here after Dr. Peter Savage said to me, do you know that the previous psychiatrist that we had here that was full-time committed suicide? So I have stayed, and there have been courageous moments in my life. But the courage that I'm talking about is different. Courage is the successful management of fear. And life, as we get older, is full of fearful experiences. In sickness and in health, in good and bad, life demands courage of us. Just like it takes courage for a person to cross the threshold of a mental health clinic in full view of the whole neighborhood, knowing that you're going to the mental health clinic. It takes courage to live with someone with a terminal illness. And it takes courage to arrange for the burial of a favorite child. That's the kind of courage that I'm speaking about. And that's the kind of courage that I have been able to bear witness to. It is truly humbling to be in the presence of that type of courage. As healthcare providers, we ask the most personal questions, and strangers tell us the details of their lives. They show us their wounds, they tell us their woes, and they confess their sins. What a great privilege it is for all of us to be given such trust. We should never assume that that trust is ours for the taking, or we should take it for granted. It is the incredible foundation for a special relationship with another human being. So if our patients have the courage to live their life story, and they have the courage to tell us their life story, we should have the courage to listen to it, and listen to it in the manner that they wish to tell it. We should honor them, and we should be pleased to walk with them on that journey for as long as they feel that they need our assistance. So, truth number 3, hope. As we age, life becomes filled with loss. Some of us know that we've had more summers than we're going to have. We know about the empty nest. We know about downsizing, decluttering. We know about the 3 Ds: droop, dribble, drool. We know about getting ill, perhaps getting cancer. And we know that our social life begins to revolve around the funeral luncheons and not about parties. All of us hope to meet this challenge of aging with integrity and not despair. We hope that there is meaning to this thing that we call our lives. Our challenge as healthcare providers is to administer hope in the right dose, at the right time, and in the right particular way. Sometimes it just means saying to the person in front of us, I have enough hope for both of us. You step onto my coattails and hold on to me, and we'll move forward. So, 3 minutes has passed in a flash. 30 years have passed in a flash. Life passes in a flash. Flashing lights, beeping technobaubles are part of modern healthcare, and only as important as the provider who is willing to enter into a special relationship and who can recognize courage, serve with humility and gratitude, and finally give the gift of hope. Thank you.
Yeah, thank you, Anne. Next, I'd like to introduce Dr. Mira Ray, Director of Center of Applied Research and Innovation at Georgian College.
Hello, good morning. I'd like to take this opportunity to welcome everyone here to this event on behalf of Georgian College and on behalf of the Health and Wellness academic area in Georgian College. Georgian College has 7 campus locations in the region, one of which, our South Georgian Bay campus, is located right here in Collingwood. We have over 125 different academic programs, many of which are currently training students who will serve the healthcare sector here in the region and in Collingwood, ranging from nursing to social work to therapeutic recreation. So it's so exciting for me to see a coming together of the different healthcare professionals to talk about research and innovation. As a college, we are completely committed to supporting the communities we serve, including the South Georgian Bay area, and working with those communities to develop relevant programming and research opportunities. And I think this day is an example of that. We've had two faculty from our health and wellness program, our Bachelors of Science, Dr. Jacqueline Limoges and Dr. Sarah Lancashire, who've been working with the organizing committee for the past 12 months to plan for this day, to organize the events. And unfortunately, they can't be here today because they are at the Canadian Nursing Association AGM, but they do send their regrets. And I know they spent a lot of effort and have really enjoyed working in partnership with the hospital. As well as our Dean of Health and Wellness, Faye Lim Lambie, who is currently on Barrie campus celebrating the convocation of those students who will be coming and entering the workforce in the health sector as well. We look forward to this event, seeing the planning unfold, but also look forward to continuing and strengthening the partnership with the community, with the hospital, in planning Research and Innovation Day for next year. So welcome, enjoy, and thank you for having me here.
Great. Thank you so much. And so we're about to get started with our first speaker. And before doing that, again, always important to give thanks. And I want to thank our contributors, Martin Riedler from the town of Collingwood, Cindy Griffiths, Georgian College, and Peter Wells, Rural Ontario Medical Program, and most importantly, Michelle Hunter. I know she's in the room. She's over here. Thank you so much, Michelle, for doing all of this. Always puts all of this in motion, and really wanted to extend that. So thank yous first, and now we'll get right to it. And our first speaker is Dr. Samir Sinha. And he's going to be speaking today about acing age-old issues in the care of the older Canadian. And our Dr. Sinha is the Director of Geriatrics at Mount Sinai and the University Health Network Hospitals in Toronto. He has consulted and advised hospitals and health authorities in Britain, Canada, and the United States, and as well as China, on the implementation and administration of unique, integrated, and innovative models of geriatric care that reduce disease burden, improve access and capacity, and ultimately promote health. So please give him a round welcome, and thank you so much.
So thank you very much, Michael, and thank you for everybody for coming out today. It's great to see that, especially that this year's Innovation Day is focused around aging, and so you have an all-star lineup, and I'm happy to lead the pack and share with you and help frame the day as we start talking about a number of different aspects of geriatric care. So I have no disclosures to give you, but I have objectives. And these objectives include just talking a little bit some of the problems that we actually have in the way we currently are geared towards delivering care, and why I always argue that they require an elder-friendly approach. I'm going to just talk a bit about the elements inherent into an acute care for elders approach to care, and then talk a little bit about the strategy we've implemented at Sinai, but have also been working with hospitals across Canada and around the world now to really help transform the way they provide care so that we can better meet the needs of our aging population. So I like the invocation we had just before, talking about, thinking about what we learn from our patients over time, and how we start thinking about aging, and how we think about the importance of courage, we think about the importance of love. And then I also think about how we actually think about aging in general. And these are two terms. Well, I think the second term is the term we often hear quite a bit, and that's the idea of tsunami. How many people have you heard referring to aging as a tsunami? Yeah, pretty much everyone. How many of you hear it talked about as a triumph? Maybe a handful, right? So it's this idea, is aging a tsunami or is aging a triumph? Well, I'm going to ask that all of you after today never use the term tsunami anymore, because anybody who uses the term tsunami doesn't know what they're talking about. Why? Because if you know what a tsunami is, these things happen without warning, right? Leave death and destruction in their past, right? They just pop out of nowhere. But have any of you heard of something called a baby boom? Okay, because if you were aware of that and kind of knew that, God forbid, these people might actually age over time, right? We kind of knew that we were aging, right? We knew that we would actually get here. But now, you know, we have a lot of policymakers who are like, what? You know, like, and even Michael just talked about some of the statistics that are going to be happening. You know what the future is going to look like in Georgian Bay. So why is this a surprise to any of us? That's not a tsunami. That's just bad planning and forecasting, right? So that's the opportunity. But why do I talk about triumph, right? Why do I emphasize that word? Because what was our life expectancy back in 1900 here in Ontario? Oh, you got a lot of pessimists here. Okay, yes. So we have 45. I heard someone say 25. It was actually, so in the Roman Empire, it was 35 years of age, okay? But actually, back in 1900, it was 51 years of age. Okay, that was the average life expectancy. Today, it's about 82, right? So when people say, what was the greatest achievement of the 20th century? Some people say we put a person on the moon. I think the fact that we almost doubled our life expectancy is pretty damn good, you know? So how do we think about that? And this is why I try and emphasize the triumph of aging and that opportunity. But as you've heard, aging isn't easy, right? And we've got to be prepared for it as we move forward. So I just want to share with you some statistics here just to help frame, you know, why we need to be thinking about our aging population in a little bit of a different way. So when you look at our stats in Canada right now, of our older population, we know that 17% of our current population are 65 and better. But we know that this number is going to double in the next 20 years, right? So the number of older people are going to double. The number of those who are 85 and better is actually going to quadruple. And who knows what the fastest growing age group in Canada is today? Over 100, absolutely. That's the fastest growing age group in our country. Now, when it comes to healthcare, because when you start thinking about, okay, you know, the beds we have here at the Collingwood General Marine, you know, when you start thinking about how many hospitalizations are accounted for by this small proportion of the population, we quickly see that older adults represent 42% of our overall hospitalizations across Canada. But we also tend to see that older people tend to stay longer in hospital than younger people, and that's why we know that about 59% of our hospital days in Canada are accounted for by older adults, right? So it's remarkable because then all of a sudden you see that you know, very few hospitals actually say geriatrics is our core priority. But I argue that geriatrics is the core business of any hospital that's caring for older adults. It's basically what we're doing today. And you can imagine, I grew up in Winnipeg, and I come to Ontario for my medical training, and then you're like, wait a minute, I think in Ontario, your senior strategy is that when you turn 65, maybe you move to Collingwood, but you don't get a place on the water, you get it in the hospital, right? Because I bet you, if you count all of your beds here, you know, you've got people who are like, yeah, like they show up with their suitcases, and they're like, apparently this is where the action is, right? You know? So all of a sudden, this is the paradigm that we actually have. But this is where it gets complicated because people think that, wait a minute, all older people live in hospitals. But we've all heard those rumors about there are older people like my parents who are still practicing as physicians. You know, they're also planning on playing with the grandkids this summer. They're also planning to do some travel, right? They're not planning to go live in a hospital, maybe work in one, but not live in one. So the question is, you know, wait a minute, why do we have so many people living in hospital, but we hear about other people who are living beyond? And we actually know that 10% of our users of healthcare, of our older users of healthcare, actually account for 60% of all healthcare spending related to older adults. Let me put that in perspective. So our current healthcare budget in Ontario is $60 billion, okay? Half of that spending, around $30 billion, is accounted for by older adults. Now, there are 2 million older Ontarians today. And 10% of those older adults, 200,000, account for about $20 billion in spending, okay? So a very small proportion costing quite a bit. And when I showed this data to our Minister of Health about 5 years ago, you know, she reasoned with me that it would probably be cheaper if we actually just gave each of those 200,000 older Canadians their own geriatrician, a nurse, and a family, right? Because it would probably be cheaper to care for them that way than in our healthcare system where it's very costly to care for these individuals. And why is that? Because when you look at this 10%, these 200,000 older Ontarians, we know they tend to be characterized by three factors, right? These are the people who spend most of their time in hospital. Number one, having what we call multimorbidity, multiple chronic health issues. Number two, having challenges with their functional abilities, their ADLs, their IDLs. And number three, they might be what we call socially frail, right? Having challenges, coping in the community with basic tasks like getting a prescription filled. In fact, we know that 27% of older Ontarians tell us they don't have a family member or friend close at hand who could help them do that task. So this is a challenge. This is what characterizes this population, and it helps us to understand why it's so expensive to care for them in a system that wasn't designed for them in the first place. And therefore, we get this issue. Right now, we hear about this theory or this idea of Canadians being stuck in hospital every single day. It's what we call our ALC crisis or our ALC issue. And we have about 7,500 Canadians who are stuck in hospital each day. They want to be able to go back home. They want to be able to go to a long-term care rehab hospital, but they can't get there. Why? Because we don't actually have the right capacity in our system in order to help people to get where they need to go. And so that means about 16% of our current hospital beds in Ontario are accounted for by people who are stuck. They just can't get where they need to go. And that ends up costing us all as taxpayers even more money, because it's about $2.4 billion a year is what we spend just around the cost of people just waiting who are stuck in a system and they can't get around. And part of this then starts helping us understand, well, how did we get here in the first place? Because I took a bunch of healthcare leaders, deputy ministers and ministers over to Denmark a few weeks ago so that we could actually do an exchange, because Denmark actually remarkably runs a very similar system to the way Ontario runs, but they don't have hallway medicine, right? But then they were saying, we were meeting with their Minister of Health and said, well, tell me about your universal healthcare system, because your universal healthcare system you created 50 years ago when the average Canadian was 27 years only includes hospital care and physician services. In Denmark, when they built their system 50 years ago, they included things like medications, home care, long-term care. In fact, all of those are essential parts of the system, and that's why their average length of stay in the country is 3 days. 3 days, right? No hallway medicine. They just find it so bizarre to understand what we have, but they say, well, maybe take a look at what you call universal health care, because it doesn't sound terribly universal to us. So then the challenge is we've got people like my patient, Mr. W, who this was a portrait taken on his 100th birthday. This was during my follow-up home visit with him. And here's a guy who basically, was doing quite well on his own till 98. Lots of courage, lots of love, doing his thing. And then all of a sudden his CHF, his COPD, his arthritis, all of that kind of came home to roost. And all of a sudden he couldn't easily get out of his house anymore to go and see a doctor. And so for him, he became homebound. It was hard for him to even get down to the ground floor of the building he lived in to get his groceries and to get his medications. It worked really well for him up until 99, until he couldn't get out of his own apartment. And that was a challenge for him. And so all of a sudden, the only way he could start accessing care in our system was by calling an ambulance and going to one of the downtown hospitals. In fact, by the time I met him in the fall of 2010, he had actually been to our downtown hospital 7 times. Goes in, says hi to all the nurses and the docs, gets patched up, gets sent back, and then we'll see you in a month? Yeah, sounds good, right? Because I'm not going to get the care I need at home to be able to stay independent and healthy where I want to be. So this is a slide that I think really helps to illustrate kind of the fact that when we actually look at aging and hospital use amongst those who are 70 and above, this is a study that was done over 20 years ago, but the data actually holds true in Ontario today. I already revealed to you some of that data, but this is a study that looked at 7,000 older adults over a 7-year period and simply asked the question, how often do they go hang out in hospital? Because remember, I had that theory that when you turn 65, apparently you go live in hospitals. So I actually looked up this paper and it said, actually, no, Samir, that's not the case at all. In fact, over a 7-year period, the 7,000 older adults who were followed in the American Longitudinal Study on Aging basically showed that half of them never went anywhere close to hospital. Again, they were, playing, in the community, doing their thing. They were staying very far away from our hospitals. About 24% were those individuals who used the hospital once over that 7-year period. And that might have been to get an elective knee or hip replacement so they could continue living healthy and active lives. The rest of the pie that would add up to 100%, so about 33% of these older adults used the hospital 2 or more times. And in particular, this gentleman, Walensky, who did the research, he established that about 6.8% were what he classified as inconsistently high users, and then about 4.8% were those who used the hospital on a consistent basis. The consistent people, like my patient, Mr. W, who you just met, who had CHF, COPD, that brought him into hospital like clockwork, the inconsistently high users, take him and then give him a mental health diagnosis or dementia, because that makes your use of healthcare highly unpredictable. In fact, having a diagnosis of dementia increases your risk of hospitalization by threefold, right? We don't remember when they're going to stop taking their medications or their insulin, and then lands them in. But the key part of his work, and the key part of what I just showed you before with our Ontario data, is only a small proportion of older adults are extensive users of hospital services. And remember what I said before, what defines that 10%, that greater group, that again, 200,000 people in Ontario that cost $20 billion to care, it's these three factors: polymorbidity, having functional impairments, and again, that concept of social frailty. Right? So now as a geriatrician, when I look at the patients who come into my hospital, I often look for these three factors, because if I'm not addressing all these issues, if I just simply patch up your CHF, your congestive heart failure, and send you back home, and I forget the fact that you don't actually have someone to help you get your medications or administer your medications, or the fact of the matter is you're going to need a little bit of extra help at home until you get back on your feet, there's no reason why they're not going to end up back in the hospital within a few days. So it's having a better lens and seeing the people in front of us who we're caring for, and then figuring out how do we adapt our healthcare system that again was developed 50 years ago when the average Canadian was 27 and could do just fine at the Collingwood General Marine Hospital or Mount Sinai, but that 87-year-old not do so well. So you think about people like Mr. W. Mr. W is fine. He doesn't have any cognitive issues, if you will. And, at his own home, he could actually get around with a walker, and he'd have a personal support worker come in every day, get him bathed, get him dressed, and he was good to go. Like that's all he needed to do, and he was good. But of course, you then give him an illness. We'll give him a pneumonia, for example. That's what brought him in when I met him back in September 2010. And the key is that we know that many older adults, frail older adults, they have less functional reserve, right? They're not as big and robust as they once were. And so his challenge that he'd always have is whenever he'd actually get sick, whenever any of us get sick, we feel a bit weaker. And that weakness meant that for him, getting up and out of a chair, often on and off a toilet seat, became a struggle, right? He had trouble with his transfers, one of those basic ADLs. That would lead to a fall. He had a son who didn't live in Toronto. He told his son he had a fall. His son thought, yeah, I'm going out of town for business. I'm not going to be in Canada. My dad, he's 100, and he's just had a fall at home, and he's got a little bit of pneumonia. Maybe I should just send him to the hospital. So before he flew out that night, he called 911 and sent his dad to the hospital because, of course, I'm sure at your hospital here, just like our hospital, that's exactly when you have extra staff taking on extra shifts, and you're staffing up just to make sure you're absolutely ready for all those older people, who coming in on the weekend. And that's a challenge, right? Mr. W came into our hospital, a hospital just like your hospital here, where you have dedicated staff who are there to provide the best possible care. But sometimes we don't realize that the care we're providing, again, geared towards 27-year-olds, not 72-year-olds, or 100-year-olds for that matter. So these tend to be very hostile environments, right? So at our hospital, we write in the orders, Kevin will know, he trained there as well. It basically says in order to get, 600 patients their blood work on time for our surgeons and doctors in the morning, we actually are allowed to wake you up as early as 4 a.m. to poke you for blood work. Now, how many of you were up at 4 a.m.? Number two, how many of you want to be woken up at 4 a.m. to be, phlebotomized, right? Now, imagine if you're an older patient with dementia, right? And someone wakes you up and then pokes you. What do you think just happened to you? You probably thought you just got assaulted, right? Now I might have more behavioral issues. You can start seeing how this is a problem. Now, who cares that Mr. W would have his breakfast at 11 a.m. in the morning? Because I'm sorry, you're now at Collingwood General Marine. You get your breakfast at 8, you get your lunch at 12, you get your dinner at 5. And if you don't eat it at that time, it might go cold. We often strip you out of your clothes. I don't see any of you wearing the fashion that I was seeing up on the wards there. None of you are wearing hospital gowns. I don't know. Like everybody here is wearing them. Why aren't you, right? Because again, we strip you out of your clothes. I don't have the time because I'm so busy caring for so many people to learn your name. So I'm just going to call you honey, sweetheart, or dear. Yeah, might pat you on the head and say, there, dear. You can see how these can be incredibly demoralizing and not great experiences. And then, of course, Mr. W didn't feel well, right? He didn't feel great and hot when he came to the emerge. So the nurses just thought, you know what, just stay in bed. We'll put a catheter in you to help you urinate, right? We'll give you an IV, you know, and again, nobody was trying to cause harm here. But that bed rest, we know for older adults, every day an older adult is in bed, they lose 5% of their bone and muscle mass. You know, you lose percentage points of your bone and muscle mass every day. You lose 5% of your function every single day you're in bed. It's why Mr. W, when he came into hospital, he could independently get around his apartment with a rollator walker. 48 hours later, you know, by Monday morning, this gentleman was what we call a two-person assist. He needed 2 people to assist him to get to the washroom. And it was amazing to see this guy who was living independently in his own apartment, cognitive intact, and watching the student notes over the weekend saying, 100-year-old guy, most likely demented, disposition plan, nursing home. Wow, we just completely wrote off this 100-year-old within a 48-hour period, and that's not what he wanted. He didn't even want to come to the hospital in the first place. And then we wonder why we have all these people waiting for ALC and why we have all these people waiting in our system, because maybe we're not actually figuring it out well. And then we have all these other challenges that happen, you know, things that can lead to medical complications and other things. And all of this leads to more physical deconditioning. So for Mr. W, by being a two-person assist, even though his pneumonia had been treated, his delirium had cleared, he got delirious, by the way, too, in our busy emergency department, that by Monday morning, you know, even though he was actually better in some respects, because he was so functionally disabled now, it took us 2 weeks to rehab him before we could get him back home. Yeah, I decided we weren't going to send him to a nursing home. He didn't want to go. He wanted to go home. But now I always said, we broke him, we bought him, right? That's 2 more weeks now that we have to rehab him to get him back. Because he's like, I'm not going anywhere else. I'm not going to a nursing home. So you broke me, you fix me, right? So we just spent 2 more weeks. And then we wonder why 16% of our beds are filled with these people who don't want to be there, right? In fact, I always say we're almost holding these people hostage in a system that wasn't meant for them. So this is our recipe, and then of course we get headlines like this saying that, you know, our hospitals are unprepared for, you know, for an aging population, and we know that if we actually do nothing differently, again, remember, we built a system 50 years ago for 27-year-olds, and so this is actually how we spend our healthcare dollars in Ontario, 60 billion, don't forget. This is actually how we spend it based on age. Obviously, the older you get, there's more mileage that you experience. That's where more of the billions get spent, but this is actually what we forecast what our spending will be like in 2030. This is how much more money we will need. We'll need $24 billion more from what we were spending in 2010 just to finance caring for an aging population with the exact same health system I just described today. So of course you're probably looking at that recipe that I just showed you and said, well, wait a minute, maybe if we did things a little bit differently, we wouldn't actually be maiming people like Mr. W. We could probably get him in and out pretty quickly, and we might not need to find $24 billion more. Maybe, in fact, we have enough money in the system that if we do things differently, we could actually have a different outcome. And that's the challenge, is I would say that the way, not only in which our hospitals, but the way our cities, our communities, and our healthcare systems are currently designed, resourced, and organized often disadvantages older adults with chronic health issues. But at the same time, as Canadians and Ontarians, our care needs and preferences and values are evolving as a society with increasing numbers of us wanting to age in place. This is why I wrote an op-ed in the Star the other week, where I basically gave permission because, I'll ask you, this is what I asked in the newspaper. I challenged all the politicians from all parties. I said, how many of you in this room, I'll ask my question to all of you, how many of you aspire to end up in a nursing home? Are you raising your hand, Michael? No. He was just scratching his face. Okay, there you go. So, but here, we had all 3 political parties saying that they're going to build 30,000 new beds because apparently that's where Mr. W didn't want to go, and that's where apparently all of you don't want to go, which is a problem because most of you probably want more home care and community care to be available as well. So this is a challenge, right? So how do we actually look at developing an elder-friendly approach, and how do we move things forward? So when we had Mr. W in our care, that was the time when our hospital said, you know what, actually our core business is geriatrics, so let's admit it, let's embrace it, and let's start working on it. So that was my mandate at that time, and Mr. W was one of our great test cases because he came in and we just saw how many things actually went wrong. Not that anybody was trying to cause harm, but how we actually had a system that was working against him. them. And so we sat down as a group of nurses, doctors, social workers, our geriatric psychiatry team, everybody. We got together, and our community partners, CCAC at the time, etc., and we said, how do we actually redesign a better mousetrap here? And so we came up with this strategy. We basically said we want to redesign or establish innovative and sustainable approaches, interprofessional, team-based approaches that could help enhance upon service current models. We knew that this would require a shift in traditional thinking that underpins the administration and organization of most hospitals, because we know most organizations often, they don't recognize the fact that they actually are caring for older adults. In fact, when we actually established this as our priority, we were one of the only hospitals in Canada actually saying that geriatrics is a core priority. Most hospitals still don't acknowledge that in Ontario. Next, we actually said that we're not going to be adverse to identifying risk factors and needs and intervening early. You know, what we want to do is we want to make sure that we're identifying the Mr. W's, that 10%, because if we can change the trajectory for them, we can actually improve the healthcare system for most folks as well. And we want to make sure that we have a focus on monitoring our data. How are we actually doing, and how are we moving that forward? And so we use this idea of the elder-friendly hospital model, one where we actually look at the culture. We have an organization that says geriatrics is a priority. You cannot work at our hospital unless you've actually done aging sensitivity training. Whether you work in finance, whether you work in the coffee shop, if you're a volunteer, you all have to do the training. And we make sure that everybody values that we're an organization that cares about older adults, and we're an organization that understands and respects their needs. We make sure that we think about the policies and procedures we have in place. We make sure that as we're redesigning, we're doubling the size of our emergency department right now, all built towards elder-friendly standards. Our new lobby, all built to elder-friendly standards. Any redesign we do, all done. It doesn't cost any more money. It just means that we have to be a bit more smart when we think about how we do our layouts and our things as well. And how do we actually manage the care in different ways? And all these ideas work together to better improve the care of older adults. So this is actually what our work has ended up looking like over the past few days, or the past few years, if you will. And we've really focused on the importance of building community models of care. So we've really focused and partnered with our community partners, our primary care partners, and others to basically say, what are some of the things that we can do, such as creating a home-based primary care program so Mr. W could work with a team of family doctors that could actually deliver care for him in the home. We offer home-based palliative care supports as well. And we have other programs that will be familiar to you, community paramedicine, nurse-led outreach, all these sorts of things that we do to try and do better supports in the community. We also have a caregiver program that's now being spread across the province through the Alzheimer's societies, where we train caregivers caring for loved ones with dementia to better support them as well. We also focus in our emergency department about screening every older adult who comes in our doors to make sure we identify the high-risk ones versus the low-risk ones. The higher-risk ones get to work with our geriatric emergency management nurses, and they're working amongst a whole team of staff that have all been trained towards caring for older adults. In our inpatient wards, we've actually reorganized our services so that we actually cluster our frail older people onto a specific ward called our ACE unit. And that ACE unit is where everybody's gotten extra training and skills so that they can better care for older adults. And then we have a number of other programs. All of our all of our hip fracture patients get cared for by geriatricians 7 days a week. We start right when they come in because we know that they're at high risk for negative outcomes. And we also engage our volunteers to be highly engaged and trained to work with frail older adults. And then we have our outpatient services that we run as well, including telemedicine, to help get people the support they need. So I'm going to finish off quickly because I'm running out of time, and basically just give you some examples. This is our new emergency department, and I love it because our current emergency department has 2 bathrooms. Our new emergency department's doubled in the size, and we have more than 4 bathrooms there. The key is, this is what the chief nurse said, if we have many more bathrooms, there's no reason we need to catheterize patients. We can actually make it easy for our nurses to get people to the bathrooms as well, and this really emphasizes that. This is an example. You all get copies of these slides. This is an example of the simple screening tool that our nurses ask as part of the routine care to identify who's at high risk, who's at low risk, and enables them to create a care plan in place as well. This is our free online training program called geriem.com. You cannot work in our emergency department at any level unless you do this training. It's free. It's available to anybody around the world. In fact, 5,000 doctors and nurses have taken it already, and it allows people to up their game to do that care. I've talked to you about our GEM nurses, who are specialized geriatric emergency management nurses. And this is one thing that we've done. Working with our community partners, we've actually created a system at our hospital that if you're one of our high-risk patients and you end up in our emergency department, we have an email alert system that allows all of us across the hospital and the community to talk to each other. That way, when this was one of Mr. W's alerts 3 years later, when he had his hospitalization after I saw him, you know, after that, we all knew that he was there. We knew what we needed to do. We didn't need to admit him to hospital because we could rally services together. And we've changed our order set. So now if we actually say activity is tolerated, which is default, it means that you need to be up in a chair 3 times a day for meals. Because we're not the hotel. We're not serving breakfast in bed anymore. We're getting you upright in a chair because that's going to help you with your functional recovery. And we're using data that we mine from our electronic health record to help inform nurses to do real care time planning to better support their care. And the nice story is that we're actually seeing results. Now, our hospital's in a busy part of Toronto. It's growing quite quickly. And while we have the lowest emergency department admit ratio, meaning if you come to a GTA hospital emergency department in Toronto, you have a 35% chance of getting admitted as an older adult. You come to my hospital, it's 25%. So it's tough to get admitted. But we have 53% more older patients on our wards. At the same time, we've actually cut our lengths of stay for older patients, 65 plus, by 26%. We've decreased our readmissions by 14%. So we're getting them out quicker, but we're making sure they're better supported when they go home. We've actually cut our pressure ulcers by 93%. We've cut our falls by 66%. We've cut catheter utilization by 50%. All nurse-led initiatives. Our patient satisfaction's at 99%. And last year, we've saved $6.7 million because we're not paying for people to wait around here anymore. They got better things to do. And we've actually closed 25 of our medical beds since I started at the hospital now. We have less beds than ever before because we don't need them, right? And so we're working with organizations across the country. Don't think this is something that you can only do in a shiny hospital in downtown Toronto. We worked with hospitals, for example, in Geraldton, Ontario, which is about 400 kilometers north of here, and they were able to implement some of our models as well. And we've been working with organizations across the country with CFHI and CFN to help them implement some of these models of care. So there are many opportunities to think about how to move forward in terms of the integration of LINs and CCACs, and some more recent community investments can be seen as an enabler. Number 2, thinking about how do we engage our staff, volunteers, and community to build local models of care that make sense and deliver better outcomes. Leverage any enabler, housing, transportation dollars to build a continuum of care. There's a lot of good things happening in this community, and the key is how do we actually collaborate and say, how do we think about the hospital as part of a broader health system, and how do we think about our municipalities as real key partners, because it's amazing when you get everybody aligned what can be done. There's new dollars coming through the provincial dementia strategy initiatives, and these are investments that can help create more integrated care models. And finally, we want to make sure that we leverage technology and help leverage technology to improve that rural effect. And the bottom line is that Georgian Bay, providers have a lot of enablers that can allow us to advance this agenda. So I hope this is helpful, and I wish you luck for the rest of the day as well. Thank you.
Great. So perhaps what we'll do is we'll take some questions after each of the sessions, I think. So there's 3 speakers in the first sessions, and then we'll field the audience for questions then. Our next speakers are Dr. Kevin Young, Dr. Joanne Ho, and Dr. Sophia Benjamin. Dr. Kevin Young, an Aurelia geriatrician, is a physician lead on a North Simcoe-Muskoka-wide plan to improve and streamline services for the region's elderly. Dr. Joanne Ho is an internist, geriatrician, and clinical pharmacologist who researches adverse drug events in the older individual using observational research and systemic review methodologies. She leads GeriMedRisk, this one working? Yeah. A geriatric pharmacology and psychiatry consultation and knowledge translation service for clinicians in the Waterloo-Wellington region. Dr. Sophia Benjamin is a geriatric psychiatrist and medical educator. She is a co-developer and the geriatric psychiatrist at GeriMedRisk. Dr. Sophia Benjamin's research interests include systemic reviews and knowledge translation. So I'll welcome them up to the stage.
So thanks very much for having us. I'm always really glad to speak after Samir because he does such a great job of setting the tone and inspiring us. And if nothing else, I hope everybody's understood that we can provide way better health care and save money doing it. And so that's really a lot of the work that we're trying to do, is just realize that it's not about having bigger budgets. It's about doing it better and about being collaborative and looking at things a little bit differently. So what I'd like to do is take a little bit of a practical approach to how we do that or how we're looking at doing that in some of our communities around here. I'm going to try to summarize in about 10 or 15 minutes about 5 years worth of work, probably even more than that. And so I was feeling a little overwhelmed by that until Dr. Jessicas was trying to summarize 30 years in 3 minutes, so I didn't feel so bad anymore. But so basically, I'm going to talk about a little bit about what specialized geriatric services are. This is the sort of the title that we have for some of our regional programs, the history, the progress we're making, and then some of the relevant impact. And then I've invited Joanne Ho and Sophia Benjamin to give us sort of a really practical example of a new collaboration that we're starting in this area. So we'll talk about that in a minute. So the focus of specialized geriatric services is on frail seniors. So these are seniors that present with multiple diseases, multiple drugs, multiple problem areas, sort of what we would often sort of describe as the slippery slope. They might require sort of medical intervention. They might require some geriatric psychiatry intervention. There may be sort of social networks that are not well established, and difficulties sort of getting medications and getting food and things like that to the table. And there may be need for sort of a complex combination of trying to figure out what some of the social services are that are required. So it's not just the medical aspect that makes these patients challenging. It's all of these other things that we put together. But this is where it becomes fun and exciting, and where we can really make a big difference in people's lives. So in this area, to try to describe this concept, what we've essentially done is we've talked about sort of the seniors on what we call the frailty scale. So there's several different versions of this scale by Ken Rockwood. The version that we're using is the 7-point scale. And so we're looking at sort of patients for this program starting from what we call number 4 on the scale, which is sort of apparently vulnerable. So although not sort of completely dependent, they may complain of being slowed up or have some disease symptoms. Number 5, mildly frail, so limited dependence on others for some of the instrumental activities of daily living. So, the family's having to step in a little bit and do a little bit of help. Or moderately frail, help is needed with both instrumental and non-instrumental activities of daily living. The reason that we've sort of focused a lot of our efforts in this particular sort of box that we have on the screen is because this is where we see the opportunity to really try to reverse some of the comorbidity, to really put in some supports that can really try to help. And not to say that if we had somebody that was a 7 on the scale and we thought that there was something that we could intervene, not that we'd ever say no, but when we're talking about a more palliative approach and we've sort of exhausted all of the other options, we just feel like we need to be putting our efforts into those patients where we can really sort of make a difference. And then at the other end of the scale, the 1, 2, and 3, these are people that are already doing very well, and it's very important to make sure that the communities have things in place to continue having them do well, to prevent some of the decline, to have exercise programs and social programs and that kind of thing. But it's not the core business of specialized geriatric services. So we're real advocates of that, but it's not sort of the core business of what we do. So this is sort of the definition of what SGS is in our area. I'm not going to read the whole definition, but I'm going to sort of go to the highlighted points here. It's hospital and community-based. I'm a very strong proponent that we have to have a very strong community program, because if we want to take care of people outside of hospital, then we have to have infrastructure outside of hospital, and we can never sort of expect that we're going to be successful in that unless we build that infrastructure. And so most of our efforts have been focused at this point on community. Not that hospital isn't important, but we need to be pulling people out and supporting them there. And that's where we're going to have our successes. We talked about frail seniors already and what that means. It's interdisciplinary teams with expertise in sort of the continuum of care. And interdisciplinary is the core, as everyone knows, of geriatric medicine. This is sort of interdisciplinary teams, in hospital, out of hospital, different types of professions and different ways of looking at problems. And I learn stuff every day from the team of people that I work with, and I'm just so glad to be surrounded by people that understand things even better than I do. And it's also inclusive in this area of geriatric medicine and geriatric psychiatry. We've been sitting at some provincial tables where we've been sort of getting some advice from others and sort of learning from what other areas have done. But one thing that's very unique about this area is that because there's so few providers, we tend to work even more closely together across medical subspecialties and be more collaborative. And so we're actually trying to lead the way a little bit in terms of looking at how can we make sure that we are helping all these patients from even the different subspecialties of medicine. And so there's been some exciting work in that area. One of the core things that we do as part of geriatric medicine is what we call the comprehensive geriatric assessment. Essentially what this is an assessment that's done by all the different team members, and we all collaborate together to provide our different perspective and our different piece. And the idea is that we look at the patient from all of these different domains. The diagnosis, which is what everybody always comes for, and the investigations and the treatment, but also like the system navigation and the education and counseling for the patient and their families, the prevention of adverse outcomes, the advanced care planning. And if we don't look at all of those other things, then really the diagnosis and the treatment is not going to be effective. This is the problem, is our healthcare system is built on just looking at those aspects, and that's the reason why we're failing at a lot of it right now. So looking at sort of this more comprehensive view is really the way that we can start to see where the real problems reside and really sort of get to the heart of the problem. So in this area, there's been a few dedicated individuals that have been working on this for decades, and I haven't acknowledged their work. And there's been a lot of people that have been, very, very dedicated to doing this. But in 2013, the Lynn Board of Directors approved some base funding for seniors' health, and that was really the first time that kick-started a momentum that we're trying now to sort of grab onto and keep going. In 2014, we completed a strategy for an SGS program in this area. A strategy document had been written previously but hadn't gone anywhere, so we brushed it off and revised it, and there's a lot of great ideas out of that. In 2015, we did a seniors health program review. There's a lot of programs in this region that are touching seniors and that are working with seniors, but we weren't working in an integrated way. Nobody knew how to refer to all of the different programs. We didn't know how to access it. Even as a geriatrician working in this area, I was confused about how to do it, and so I can just imagine how everybody else felt who wasn't doing this every day. So we reviewed that program. We made an action plan, sort of how we're going to sort of revise some of these programs and how we're going to make things more user-friendly, and not only for us, but especially for the patients. In 2015, as part of that project, Waypoint was identified as the lead agency for North Simcoe Muskoka SGS. They're through a whole RFP process. Leadership team was recruited in 2016, so really a lot of the work that we're going to talk about today hasn't started until really the end of 2016. So we're starting to really pick up momentum and get moving. One of the really important sort of aspects of all of this was that we reached out to the community and we wanted to hear from our community, what do people sort of value? What do they see healthcare looking like? What is it that we're trying to build that, these are the things that people expect that are already there. They don't understand that we don't actually have the system in place that can look after all of these needs. And so some of the things that we heard were that we wanted to avoid kingdoms and silos. It's already too complex. They wanted to be coordinated centrally but make it locally managed. And that message came through loud and clear time and time again. People sort of had this expectation that these services, they wouldn't have to travel sort of 2 hours to get these services. They'd be available in their community, that there would be some expertise that could be plugged into, but these things would exist. And so a lot of our model is really looked at, how can we augment what's already going on in the community? How can we simplify it? How can we not come in to take things over, but just to sort of help fill the gaps and really sort of work together with each community to sort of say, how can we move towards a model that is going to better meet the needs of our seniors. And so that's very, very much what the philosophy of our program is. So in 2015, there was an action plan that was put together. We talked about the designation of lead agency. We talked about Seniors Health Project Team, which is sort of the oversight committee for that. There's a leadership team now. There's office space in Barrie. We've now become members of the Regional Geriatric Program of Ontario that has just formed a provincial office, and so we have a strong voice and also some help from all of the other communities that are in some ways ahead of us, and in some ways we have some unique possibilities here. We have a physician network of very dedicated individuals that we meet every 3 months and sort of get updates and talk about where things should go. There's a geriatric nurse practitioner community of practice, and so we're trying to sort of reach out and get input from all of these different levels of people. And then we're aligning with sort of a lot of these, the provincial dementia strategy and assess and restore and all these sort of things that you've heard about, and making sure that our work sort of, not only is going to meet the needs of what we're doing locally, but also is going to be in alignment with where the province is going. So this is the quality framework. I'm not going to go through it in detail, but we have some posters around, and there's many of the managers from our program around today, and they're more than happy to walk through this or come and find me. But the sort of essential elements are, our vision, so wellness, independence, and quality of life in aging. Our mission, to optimize health and well-being for seniors who are frail through an integrated regional program of specialized geriatric services. And then basically we're going to do it by improving patient outcomes, building capacity, and fostering system change. So the first part of that is our overall model. This slide is actually in the process of being revised, so you'll see an even more detailed version of this coming shortly. But the idea is that there's central services that are there where there's some specialist physicians, there's in the future some specialty beds that don't exist yet, and some ways of very quickly being able to get advice and reach people. But that's not where we're expecting patients to come to. What we're expecting is that there's going to be local teams with local leadership and local resources that we're going to be able to help, and we're going to be able to be a support and a resource to, but that a lot of that care is going to be delivered locally. And so we're going to be working with each of the communities to figure out sort of how to make that a reality. And the truth is that every sub-region in this area has very unique challenges, but also a unique subset of culture and of resources that already exist. And so we're very much looking to sort of say, how do we plug into what's already there? How do we augment it? How do we not throw all of that out and really sort of take advantage of what's there? And so, so the local part is going to be a big, big part of all of this work. The behavior support system was a real initial focus of a lot of our work and really took up most of our time last year. We've made some huge strides forward. We've completely integrated now the psychogeriatric resource consultants so that they're part of sort of our overall teams. We had about 7 teams that you could refer to. I had absolutely no idea when you'd refer to one team over another previously, but now you just make one referral and the teams are integrated and they figure out within the team who needs to see the patient. Sometimes it's not even clear until we start to work with those patients, and so this makes a lot more sense. We have now a lot more alignment with the long-term care homes. There's a Seniors at Home project trying to look at how can we augment some of the retirement homes to be able to look after people in the community, and sometimes a little bit of extra resource is all people need, and it's the difference between long-term care and living independently. Behavior success agents. So in every hospital there is a behavior success agent as a pilot project for a year. Most of the hospitals have kept those people on, but that was a tremendous move forward in terms of recognizing some of the hospital policies that were a barrier to recognizing and diagnosing the root cause of some of these responsive behaviors in hospital, and we're going to continue to do work along those lines. And complex case resolution, where we are able to, you're able to phone the manager of the behavioral support system and set up a meeting where we have high-level people who are able to really put their brain to these patients where everything in the system that everybody knows about has already been used, and yet there's no movement, and what do we do and how do we sort of approach that? And if you haven't taken advantage of it, I encourage you to, because there's a lot of brain power that goes around that room. Integrated Regional Falls and Enhanced SMART. So there was a transition to the specialized geriatric program effective April 1st. We're currently in the process of figuring out how we can do this, a similar thing with that program that we did with BSS, turn it into one program, use those resources, not just to look at falls assessment, but to look at that more comprehensive assessment that I talked about earlier, and to really make sure that we're fully utilizing that, that resource. You know, patients that fall often do have some cognitive impairment and some social needs and everything else, and so we can't look at just falls in isolation. We need to look at it as part of a bigger system. And e-consult, there's two things that we're doing. Geri MedRisk, which we're going to talk about in a minute, and we have a closed group pilot project, which is basically going to be a more rapid way for those people that are doing geriatric medicine as their sort of core business to be able to get advice and to rapidly be able to sort of work patients through the system without having to have patients travel. It's a bit of a pilot project to sort of get off the ground, with the idea being that we may expand it out to try to help with more services and primary care level in the future, once we kind of wrap our heads around some of the technology and some of the other difficulties. And then we're also sort of trying to build capacity. There's a lot of educational projects that are going forward. Here's a list of some of them here. In the interest of time, I'm not going to go through all the education that we've done, but needless to say that this is a big part of our focus. We've had lots and lots of different things, and just look at our website. I've got the address on the final slide, and we've got lots of educational events going on. There's toolkits there about prescribing and de-prescribing antipsychotics in long-term care, and there's lots of work we've done sort of around education. And then the last thing is fostering system change. So looking at trying to make sure that we're getting the right group of people to do some of this work, and so recruiting enough specialists in this area, as well as nursing and allied healthcare and people that sort of understand this and can move us forward. We're collaborating with the mental health project team. We already talked about the regional geriatrics program and some of the work that we've done with them, and working with the LIN to sort of make sure that everything that we do is in coordination with what the LIN is doing, so that we're all in alignment. And in fact, there's been very, very good alignment with all of our programs, and a lot of the committees that we've set up and some of the work and stuff is now starting to move into other areas as well, and so that's working very well. So, I mean, at the bottom line is that hopefully you're finding in everyday life that behavioral support services is a better resource program, easier to access. Geriatric medicine, we're trying to realign the resources to match community needs. We're trying to foster the development of interprofessional teams. In this area in particular, we're very fortunate to have Dr. Mona Sidhu, who's one of the speakers later on, who comes into the community. Sorry, I'm kind of losing the mic here, I apologize. But anyway, she comes into the community once a month to do some consults. Dr. Zorzito, who's a geriatrician in St. Mike's. Also, I'm not sure if it's better or worse. I'll switch over. Okay. Okay, we'll try this one. But she's doing some telemedicine and was involved in training sort of many of us that are working in this area. So there's some local resources which we hope to continue to evolve. And then, there's been lots of educational events. We have a whole nother series of educational events coming up next year. And then one of the more exciting things that we have been doing is we have this new collaboration with a fabulous organization called Geri MedRisk, who I'm going to not take their thunder, let them explain to you what it is, and I'll come back at the very end to sort of make it practical. But I'm going to invite the Geri MedRisk folk to come and... So, Joanne? There you go.
Thank you. So it's very natural when you see all the work that Kevin and his and the team that you get to work with here in NSM have done. The first question that comes to my mind is, how can I help? And I think in geriatrics, that's usually how we start. And this is we're excited to be able to work together. There's just a very quick session. I know that it's going to be a bit of a whirlwind tour. We're going to talk about Geri MedRisk, present some preliminary results, describe a case example, talk about a capacity building, practical considerations, and then talk about how we can potentially, how we're hoping to help each other here. So here's some disclosure slides for myself as well as Sophia Benjamin, who's coming up next. Nothing from commercial interests, but we are funded by nonprofits. So these are disclosures. I'm happy to talk about this offline, but I'm cognizant of time. So it's short and snappy. They're all healthcare organizations, nonprofit, academic institutions. So here's our senior, our patients in the middle. And there's the primary care physician. Maybe they have one pharmacist, but sometimes they have multiple pharmacists. And then they have a few other comorbidities. How many of you here have had a patient that looked like this and have multiple specialists hopefully on their team? Exactly. And so when we're prescribing, hopefully people are talking, right? Hopefully they're talking to each other. Hopefully it all comes back to primary care. If the pharmacist has some questions about, are you sure you want to prescribe that anticoagulant for the person that just had a GI bleed and whose kidneys aren't working so well? Who are they talking to? And hopefully the primary care physician or clinician, nurse practitioner, is cognizant of all these details. Sometimes it gets complicated, and sometimes it's hard to prescribe for your older patient with so many medications and so many comorbidities. And after a needs assessment, as well as some preliminary work, that's where we came up with GeriMebrisk, which is an interdisciplinary telemedicine, geriatric clinical pharmacology, and psychiatry consultation service for clinicians, so for you guys. We use primarily eConsult, but for urgent cases, just like the Ontario Poison Centre, there is always just pick up the phone and give us a call. Sometimes we might do an e-visit as well, but most of the time we manage most of the cases through eConsult. And for more urgent cases, not overdoses, because that's the Ontario Poison Centre. If you just have I just want to know what's the maximum dose for this patient with all these comorbidities, just give us a call. So how it works is you have your senior, your older patient, and then they have their local team. That team can be a geriatrician, it can be a family doctor, can be a psychiatrist as well, could be a nurse practitioner, and also a pharmacist. And if they feel that they have a question, they're not really sure if it needs a full-on consult, or maybe it takes about 2.5 hours for them to actually see someone in person, and e-visit isn't something that they think it really needs, then go ahead and send us an e-consult. And we are a group of geriatric pharmacists, geriatric psychiatrists, so Sophia Benjamin, geriatrician, as well as clinical pharmacologists. And we are here. And we promise to provide a coordinated consult, so one letter from all of the specialties, if they require all of them, back to you, as well as some geriatric drug information materials. So what that means is even if you're a patient with multimorbidity, dementia, and mental health issues require multiple specialties, we promise to agree by the time we send the letter back to you. So all the fighting that happens will happen on our end. So sometimes I'm like, oh, are you sure you want that drug? And Sophia Benjamin will be like, yes, it's important. And then we'll fight, and we'll kind of, do our little showdown with our own evidence on our side. But we promise that it will be all in agreement by the time that we send it back to you. And we usually do so with a response back within 5 business days. And really, it's we have had some impact on wait times to specialists, but really it's for those quick questions, those I'm not sure if I need a full consult kind of question, especially when it comes to medications. From our pilot in the past 8 months, which is just concluded, we're just doing some kind of more further analysis. This is where most of our consults have come from. Lots from long-term care, lots from primary care, some acute care, and that slice, that 4% for outpatient specialist care is increasing. It's growing, and sometimes it's very it's fantastic to be able to support our colleagues. These are geriatricians, these are psychiatrists, geriatric psychiatrists that are consulting us and asking for help. Sometimes it's also to further refine their standardized order sets for their older patients in hospital. So as you see, we really do all work together, and there are times when we do have to do the ultimate combo consult. In terms of consult topics, it ranges. There's really a wide range. Sometimes it's dementia, lots of BPSD, delirium, mental health, adverse drug events, deprescribing, polypharmacy, bone health, and then other. in terms of our preliminary results from our pilot, just to share a few things, we have been able to prevent hospitalizations in the Waterloo-Wellington region, mental health as well as acute hospitalizations. And in terms of in-person consultations, it speaks more about the consults that sometimes people just want to have a quick, I'm pretty sure I know I need to take this drug off, but I don't really know how. And then how do I stop these 8 drugs? What would you start first? Would you stop second? How would you monitor? So, when to involve geriatric risk? I have 2 small children who like Paw Patrol. So there's no problem too big, no pup too small. Maybe, yeah. Okay, Kevin watches Paw Patrol. So I like to apply that to geriatric risk. I know we got to stick together, but really, there's no drug question, no pharmacology question too small or too big. Okay, so if it's a med list of 30 to 40, no problem, bring it on. I get really excited about that. But even if it's what's the maximum dose of drug, or should I be prescribing this medication? That's perfectly fine as well too. It's often if you're not sure if it requires a full consult, maybe if you're waiting to see a geriatric specialist or 2 and it's really hard to get to them, or the wait times, or it's just I'm not sure if I need that question. And then also questions around deprescribing. How to deprescribe? I want to deprescribe, and I run, or do I have to deprescribe? So I'd just like to turn it over to Sophia Benjamin to give a case example.
Thank you. So I'll jump right into the case. I just wanted to walk you through what happens at our end. So Joanne talked about how the organization works. So this is an example of a consult that Joanne and I did just a couple of weeks ago. So this is a 75-year-old gentleman who was in combat, came back home, and family says was never quite the same. Multiple hospitalizations, had GI bleeds, so bleeding from the stomach, and pancreatitis. And so the consult was sent both for medicine and mental health reasons. So you saw the simplified infographic picture, but this is kind of the model. So from primary care, the question is always generated from the patient through primary care, and it comes through the geriatric risk pharmacist, who actually collects a lot of the initial information. And depending on whether it's a mental health related question or it's a medication, clin pharm, geriatric question, they delegate the consult to one of us. And then if we need to talk amongst each other, then we will. So in this case example, so Joanne went through a lot of does this patient have cognitive impairment? Because there were quite a few signs that maybe he does have some impairment. And she talked about management of all the vascular risk factors. He's also had a gastric bypass before, and he was getting PO B12, so she optimized that. He was losing weight, so she suggested a malignancy workup. But the point where she referred to me was, well, is this depression? Is this PTSD? I'm not really sure how to differentiate this. And so the geriatric psychiatry part of the consult begins then, where we weren't really sure from the information that the team provided. So sometimes what we do is capacity building. We walk them through, well, it could be this or it could be this, and this is how you can make the diagnosis at your end. And it was a little complicated here because if the diagnosis was depression, the treatment would have been relatively straightforward because we have antidepressants that don't increase risk of bleeding from the stomach. But if it's post-traumatic stress disorder, which is what we thought was most likely going on, almost every first-line medication that you use can increase the risk of bleeding from the stomach. And this gentleman was presenting multiple times because he had GI bleed. So we were weighing the risks versus benefits of which treatment to suggest. And at the end, we thought, well, functionally, he's really impaired by a lot of his behaviors, and he's losing connection with his family, and there was also a risk of violence involved. So we thought, well, this gentleman really should be on venlafaxine if he has post-traumatic stress disorder. But we also do fairly rapid literature reviews, and my suggestion was, I think this gentleman should also be on misoprostol, but I don't prescribe it. But that's when I can turn around and say, Joanne, what do you think? And so we add that part to the consult, and then we send an integrated consult. But what we also send is prescribing information that's tailored to seniors. So with every consult, we also send back Jerry MedRisk, and it's too small to read, but when it comes as an information pamphlet, you can read it. And it's for seniors. It talks about drug interactions, but we will also help the clinician have that conversation with the patient, talking about, for this particular patient, when you use this medication, this may be the number needed to harm, and so that they can have those informed discussions with patients. This is another example. So one of our big goals is to build clinician capacity to take care of seniors across the province. And we have monthly clinical pharmacology, geriatric psychiatry, geriatric medicine rounds, which are now attended by multiple sites. And we were actually having a conversation with a pharmacist from Thunder Bay about how we could build capacity in their region through some of our rounds. We've also had a lot of postgraduate trainees, so residents from family medicine, internal medicine, clin pharm, geriatric psychiatry, psychiatry. So 15 trainees in the last year. And through different talks, as well as didactic lectures. So we've covered a lot of individuals, and we usually talk about whatever they are interested in, a drug-related topic. And all of this is entirely industry-free. So for the physicians here, I just wanted to include a practical slide about e-consults. So when CMPA has done an audit of the whole e-consult process, and their evaluation is that, well, it's an improvement on the telephone and the hallway consult, which we all do because it provides a very clear trail as to who said what at what point. And the consent from the patient is implied, and so we become part of the circle of care, but it's good to inform your patient about it. And the MRP is always the primary care provider. And they close the consult and they institute the changes, so they have the discussion with the patient. And as a member of this team, I just wanted to include some reflection. So working as part of Jerry MedRisk, it's encouraged me to learn, and it's kind of stretched my learning with every consult. It's increased my capacity to manage medical patients. So in the example, I may have had the question about misoprostol, and I may have written another consult. And it may have been another month or several weeks before they saw a geriatrician who then provided that information. So it's really helped provide better care for the patients, and it's helped me understand the kinds of questions that can and cannot be answered by e-consults. Sometimes with behavioral questions, they may ask, is this depression or is this apathy? I find that really hard to answer as an e-consult. So there are limits to what we can do as a remote team. But we are very excited to collaborate with Kevin, and I'll hand it over to you.
So we're out of time, but I thank you very much for that introduction. Just very briefly, so we're actually looking right now at trying to have a pharmacist that will be on the ground in this region that we'll share in collaboration with Jerry MedRisk. We're going to be looking at the numbers and the types of consults and using that as a guide to what types of services we need to grow here. And any cases that Jerry MedRisk sees that feels that they need a geriatrician or geriatric psychiatry consult, we'll be working with them to try to provide some of that. So hopefully you can use that service, and thank you for your time.
Great. Thank you so much. Our next speaker is Dr. Trudy Bergère, speaking to us about seniors engaged in lifelong learning. And Dr. Trudy Bergère is an award-winning educator, published author, and presenter at national and international conferences. Dr. Trudy Bergère is one of the 5 founding faculty members of Georgian College's Partnerships Center. Dr. Bergère completed a PhD in curriculum studies, science education from the University of British Columbia in 2011. And for the past 4 years, the scope of Dr. Bergère's interest has expanded to curricula for senior learners, something that is new at Georgian College. So please welcome up to the stage.
Thank you very much for that nice introduction and for the warm welcome. And I don't know about the rest of you, but the topics this morning I've enjoyed so much. It's just been wonderful. So I feel really honored to be here and to be speaking to you today about this topic of senior learners. So just to start off with, given the context, we're kind of into doing something a little bit different now, because I'm not speaking to you but from a clinical perspective. I'm not speaking to you from my biochemistry background. I'm speaking to you as an educator and how that fits in with the idea of aging. So this is where I'm going to be going with you today, looking at how healthy aging is connected with learning, and then also how curriculum fits into this package. So the idea of people learning, and particularly seniors learning, is not really anything new. This has been going on for years and years. Since the early 70s, there's been something called the U3A model, which started in France, actually, the University of the Third Age. And then that changed and evolved and went into education under the British model, which was a little bit different, but generally the same, and has spread across many, many countries of the world and across all 5 continents. So that idea of learning at when people are seniors is not really new. What's new, and what I'm going to get to today, is how we approach learning for seniors and how that fits with healthy aging. So I'm going to just explain a little bit more about what I mean by that term, healthy aging. And I'm getting that term specifically from the Canadian Medical Association. And they recently released a document called Demand a Plan, and which was presented at the federal level. And they gave a definition that was borrowed from public health, saying healthy aging is the process of optimizing opportunities for physical, social, and mental health, the things we've been talking about this morning, to enable seniors to take an active part in society, underlining active, without discrimination, and to enjoy independence and quality of life. So that definition encompasses a lot of aspects of just living at this age, but also fitting in with aging, in particular, some of the things that we've been talking about this morning. Another definition I came across was from a different perspective, not just the medical perspective, but this term called successful aging, which comes from the gerontology perspective, a multidisciplinary perspective that brings in sociology as well as culture and race and economics, various different things. So successful aging, according to Dewey and Bryan, has 3 components to it. The first is this idea of the social aspects of aging with others, so bringing in that idea of the other into this picture, as well as developing strategies, actual tangible strategies, so people are able to cope with those changes related to aging, and also being able to maintain, again, we saw this earlier, the physical and mental health, but also the ability to pay for it, so to be financially stable at that age as well. So if we put these things together, we might say, okay, we understand a little bit more about now what I'm talking to you about with aging. And so where do we go from here? So I have to think about who are the people we're talking about that are aging. And if we think who is aging, who is learning, then we use these descriptors in various different ways, in social settings, in personal settings, in professional settings. In many places, it's okay to refer to somebody as an elder. It's okay to refer to people as a retired person. But as an educator and professor, I would not say old people. So some of these things are very contextualized. They can be respectful in some places, but not where I'm talking about today. I like, in this context of education, is to refer to people as senior learners. It's a respectful way to talk about this group, and it's also a way to avoid ageism, which I've encountered with my own mom, dealing with that, and also the idea of ghettoizing older people. So avoiding some of that in a very respectful way. So there are a few things that we do know for sure at this point. And this is about learning and what the research is telling us. So I have 4 kind of snapshots of a huge amount of literature for you that I'm going to share in just these few minutes. So the first one is, and it's been validated by all the things you've heard so far in the program this morning, is that later life looks different now than it did for my mom's generation or my grandmother's generation. It's very, very different, and that's evident, but the research explains all of the evidence behind that claim. Another point is that our existing notions of lifelong learning, which is in the title of my talk today, is actually outdated. So things are changing because our lives are changing because later life looks different. So that whole idea of lifelong learning is becoming, that term in education is becoming a bit obsolete and outdated. So we're replacing that with new ideas about education. That's what I'm going to talk with you about. So the third part of the snapshot is that education at the post-secondary level has a positive impact on individual and societal public health. So we were talking about the healthcare system in the first two talks, and what if we can make a positive difference before that those systems and all those processes are necessary. So the idea about well-being, the idea about successful aging and healthy aging, what if we could do this? The fourth part of the snapshot is that education might result in a decreased burden on public resources and services and add new knowledge into our society. So we don't just write off people anymore because they're senior learners. They might actually have more to contribute to our knowledge base in society. What a novel idea. So I look at this research and I say, yeah, this is interesting, but it's kind of up in the cloud stuff. Even though we may relate to it on a personal level, it's still kind of up there. So one of these studies that came out actually had a really interesting quote that I'd like to share from an actual senior learner. So the name that's used in the quote is Robert, and that's a pseudonym. And I've invited a gentleman whose name happens to be Bob, just by coincidence from the audience, to read this quote for you. So the idea of what is actually being said about all this research that's up in the clouds. Take it away, Bob. Thank you very much, Bob. Well said. Well said. So with that in mind, I'd like to think about now, if you could follow along this line of thinking with me, what else do we need to know to fit into this as we're talking about the connection between learning and healthy aging or successful learning? So for some reason, the slide is not showing the text. So just let me share this with you. So as we talk about what else is important, if we follow the line of thinking, if learning is essential to learning, learning is essential to aging, which is what we've been talking about until now, then senior learners must be able to look to our public institutions for that learning. So they can look to those institutions. They can also look to the community groups like the Third Age Network. But our publicly funded institutions have a responsibility at the level of the community. So senior learners should be able to look to them. And the most important point about, if that's true, that learning is essential to healthy aging, and senior learners could look to our institutions to do that learning, then learning must be addressed in a way that's beneficial to those learners, just as care is being addressed in a way that's beneficial to patients in the hospitals. So with that in mind, what we have thought about at Georgian College and at other places, we spent a lot of time thinking, what would a learner-focused curriculum look like? And how is that different than the traditional path that we have followed and other institutions have followed in those different ways? So I've been working with local groups in the community, and this is a very small snapshot of one group that I worked with, and these are residents of an assisted living home in Barrie. And each of these individuals came into this activity that we were doing together with very different needs in terms of learning needs. They had different interests in what they wanted to do. They weren't all interested in, we were doing astronomy this day. They weren't all interested in that. But by the time they left, they became more interested. And they also have different learning abilities. So again, we see some similar things when we're looking at someone coming into healthcare. So the idea of needs, interests, abilities. But the other part that's very important for education is this idea of life experience. So these senior learners are very different than our typical college students because senior learners have decades of life experience, versus my other students that are 17 and 18 in the classroom have a different life experience, still important, but this group is unique. Therefore, a senior learner-focused curriculum has different aspects. It has an aspect of being effective. So an effective curriculum will consider these needs in advance, something that we don't typically think of. We will consider that these senior learners are different than our college students. The curriculum is also is successful when people actually come into some type of learning environment and actually learn something. So because we've been able to address those needs in advance. So the idea of curriculum is connected into that picture of aging with learning, because we can do learning and we can offer courses in various different things, but is this with a sensitivity and awareness of the abilities and needs and life experiences of learners. So I find in this group of folks that I had, a lot of them just wanted to come to be with other people. They just wanted to be social with each other, and we talked about that social health, right? And sometimes they just want to talk to someone else about what they've done in their life. So what if, just by doing this type of thing, we could help people maybe not get to number 4 on that scale of frailty? What if we could help them through learning stay at number 2 or stay at number 3 just a little bit longer? Would it make a difference? So we're back to the idea of the connection between healthy aging and learning, supported by and augmented with this idea of a specialized curriculum for senior learners. So if we were able to design a curriculum that fit senior learners, their needs, their abilities, their interest, and their life experience, and then through that they were actually able to learn something new about themselves or about a topic, and that was able to help them age in a more healthy way in terms of their physical health, their social health, their financial health, their mental health, all those aspects we talked about, and maintain quality of life at any stage of natural aging, then I think that's been a good day. Yes. So thank you very much. I'll leave you with this.
Great. Thank you. So I'll take this opportunity. Our first morning session of speakers is completed, and I'll open it up for questioning from the audience. And so, great.
Very nice statistic of reduced ER visits from 35 to 25. Was there any follow-up of that 10% as to where they landed back in the community? Was it through an intervention, or like that data being brought back into finding out, are we just rejecting these people? Are there some success stories? Just where did they go, that 10%?
So just, very quickly. I mean, the key is that whenever you're trying to do interventions, the best thing is to, look at your data. And what we say is we have various measures, like we will measure the length of stay in our hospital and say, yes, we're decreasing, we're getting out people quicker. But then, of course, people could say, well, are you just pushing them out the door and they're coming back tomorrow? That doesn't count, right? So that's why we always hold ourselves to what's a good balancing measure. And so we would look at the rate of readmissions within 30 days to show that we are not doing well. So the key thing is, and I think it builds on what Kevin's piece was, and we've been working together on this for years, is about, building those community relationships. So our emergency department has declared itself no longer the front door of our hospital, it's the front porch. No, and it's a very different philosophy. Our Emerge docs, if you're a primary care provider, you call the Emerge with a question, you want to talk to one, they will answer the call within 5 minutes, right? Because we want to make sure that we can give people that advice, kind of like what Joanne was saying. And often what we find is, so what we said is, in our emerge, in Toronto, 35% chance of getting admitted to hospital. Because sometimes the emerge docs say, well, it's easier to admit the patient to hospital than to do this. By bolstering with the skills in the emerge so that people just know that, wait, I might need to talk to our GEM nurse, or we've got some services in the community, then how do we link them with that? And what we've seen is, for example, through a lot of those other community partnerships that we have, where our GEM nurses are the prime connectors. We don't make the ED doctors the experts on who to connect everyone to, but we say, if you have a question, you need to ask, and if you ask that question, we'll get an answer, and we'll figure those things out. And so what we've actually seen over time is our latest data shows that the volume of patients coming to our ED is decreasing because we're having better interventions in the community to prevent people coming. So I'm not going to bore you to details of all the other data, but we're actually showing that overall, what's nice now is chapter 2 of our story in downtown Toronto is we're actually seeing decreased volumes coming to the EDs with some of our more upstream initiatives like community paramedicine, et cetera, that stops a 911 call in the first place.
That's great. Another question?
Dr. Shmira, you mentioned earlier who would go to a nursing home. I would, because far too many people, both the patient and the caregiver, don't take into account the cost to the caregiver. And when the caregiver walks out onto the driveway and drops dead, how much worse off is the patient?
No, absolutely. And what we want to do is we want to make sure that we have a system that honors everybody who's a part of it, right? So number one is, I've never said I have anything against long-term care, right? We have 80,000 long-term care beds. We have 90,000 people who work in long-term care. They provide excellent care every day, right? Despite what you hear in the media, there are 90,000 great stories happening every day. And long-term care is a vital part of our system. And a lot of the work we've been doing, it's part of our senior strategy, is making sure that long-term care can be a place where we can provide the right care to the right people at the right time. You're absolutely right. There are situations in my clinic where I'm encouraging, almost badgering the families to think about long-term care because it is the right solution. But in many cases as well, sometimes the caregiver is suffering at home because they're not getting access to the right home care they need. They're not getting access to the right supports and everything. So the key is always looking at everybody. Again, think about those 3 factors, right? If you're just saying, if we're saying, are we actually attuned to the needs of caregivers? Are we attuned to the needs of the patient? Are we attuned to the home care needs and what else we can do? Because often the challenge we have is when people are prematurely institutionalized. The challenge when we're actually not actually meeting people where they need. And so you're absolutely right. The situation you described, it's not an ideal situation if we're not supporting the caregiver, but the key is how do we make sure people get the right care where they need it with the right provider? So I think we're in complete agreement.
That's great. I'll take one last question.
This question has to deal with falls and medication. So I don't know who's going to handle it in terms of a response. But I've been told that as a senior, if I'm close to 80 years old and I take 8 different medications, I have an 80% chance of falling. That's what I've been told. I don't know if that's true or not. My question is, if I'm going to take all these medications and I'm going to have an 80% chance of falling, 60% of those of us who go through falls don't survive. So is there some sort of thing that needs to be done where medicines get tweaked, after a year or two, and people's medications are assessed in terms of their falls?
Great question.
Thank you for the question. Yes, absolutely. Short and snappy, or can I elaborate? Oh, okay. You're absolutely right. We hope that every single time that a medication is prescribed, or every single time you go and see your clinician, your healthcare team, someone's looking at the full list going, do we really need to continue this medication? Can this dose be decreased? Is this medication really giving you the biggest bang for the buck? There are some things that we know it just doesn't work very well anymore. Are there any drug interactions? Those are the questions that I love to ask, and I can say probably all of us here are nodding. That's our favorite thing to do. We hope it happens in every single healthcare setting, hospital, office, outpatient, and we hope to be able to help everyone to be able to do so.
That's great. I'll ask if you have other questions that you come up and maybe speak to the speakers and ask those personally if you wish. At this point, we're going to take a break. We're a little bit behind, so we're 20 minutes behind. We're going to make it 15 minutes behind, so we'll be coming back at 1:45. So this is a time to stretch. There are some posters in the hallway. I do want to make a comment. There is a McMaster's Optimal Aging Portal, and this is an opportunity for individuals to sign up and receive some benefits about aging. And there's signs to direct you there. And I'll reiterate that because it's hard to hear. I'll see you back.